Hi everyone, our subject today is upper GIT bleeding in pediatrics. Upper GI bleeding is defined as bleeding from source within the GI tract proximal to the ligament of treatise. Risk factors: chronic non-steroidal anti-inflammatory drug or steroid use, bleeding diathesis like hemophilia, chronic disease leading to portal hypertension like cystic fibrosis, congenital hepatic disease can cause varices with subsequent bleeding. Severe retching or repeated vomiting can result in upper GIT bleeding. Inherited condition of vascular anomalies like Osler-Weber-Randu can predispose children to upper GIT bleeding. Severe head trauma causing Cushing ulcer or burns causing curling ulcer. Clinical overview. GIT bleeding may originate anywhere from the mouth to the anus. Upper gastrointestinal bleeding is much less common in children than in adults because of rarity of GI cancer. When hematemesis is caused by brisky bleeding, it usually indicates an arterial source. Coffee ground emesis result from blood altered by gastric acid and usually means that the bleeding has swallowed or stopped. The causes of hematemesis vary according to the age of the child and whether there are other associated symptoms. Hematemesis usually associated with nausea, act of vomiting, pain, and possible tenderness of the abdomen must be differentiated from hemoptysis associated with cough, frothy color, crackle, noise on lung auscultation, and evidence of pulmonary disease, and swallowed epistaxis, blood present in the nose, dripping into the posterior nasopharynx. History. The typical history is vomiting of blood that is bright red or coffee ground color. Parents may report dark tarry stool, meline, which may be the result of an upper GI source of bleeding. The history should include a careful inquiry about associated symptoms such as retching or recurrent vomiting, chronic medical conditions, medications, family bleeding, or vascular disorder. In breastfed neonates, ask about maternal cracked or bleeding nipples to identify potentially swallowed maternal blood. Definitive diagnosis can be made by Abt-Downey test. Formula-fed infant inquire about formula intolerance, which could signify milk protein allergy seen with both cow's milk and soy-based formula. Inquire as to non-GI source of bleeding such as cough, which could indicate hemoptysis, or epistaxis, which may be swallowed blood. Physical examination. Careful documentation of vital signs, especially heart rate and blood pressure, will help identify life-threatening hemorrhage. Inspection of the nose is important to exclude this non-GI source of bleeding. Abdominal tenderness and peritoneal sign may suggest life-threatening GI perforation, while hepatomegaly or splenomegaly may suggest portal hypertension. A thorough exam of the skin is important to identify stigmata of chronic liver disease and vascular malformation. How to approach to GIT bleeding after performing history and physical examination with confirmatory test for blood. Identify the source of blood. If it is lower GIT bleeding, meline, is there a suspicion of Meckel diverticulum? If it is yes, Meckel scan, diagnosis, Meckel diverticulum. Other bright red bleeding, blood in stool, and hematochezia, occult blood will be discussed in lower GIT bleeding lecture. If it is upper GIT bleeding, hematemesis, is it swallowed blood, non-GIT source? If it is yes, differential diagnosis, epistaxis, swallowed maternal blood, procedures like dental procedure or tonsillectomy, and hemoptysis. If it is not swallowed blood, or if it is there is no suspicion of Meckel diverticulum, send patient for CBC with differential and platelet, PT, PTT, APT, liver function test, blood urea, creatinine, refer for endoscopy, imaging. Differential diagnosis may include Mallory-Weiss-Tear, esophagitis, gastroesophageal reflux, gastritis, peptic ulcer, disease, esophageal or gastric varices, foreign body, intestinal malformation like duplication, Webb's malrotation, valvulus, vascular malformation, tumors like leiomyoma, pyloric stenosis in infant, hemorrhagic disease of the newborn, and coagulopathy like hemophilia. Recommended investigation. Confirming the presence of blood is important to avoid an unnecessary evaluation. Munchausen by proxy should be considered if a history of significant bleeding is not supported by an documentation of actual blood loss. Full blood count. Anemia suggests chronic blood loss or large blood loss, thrombocytopenia. Coagulation study, PT, PTT, clotting factor, and liver function test. APT test, maternal blood turns yellow-brown, or fetal blood remain pink. Abdominal plain X-ray useful for necrotizing enterocolitis or foreign body. Endoscopy for upper GI bleeding. Top tips. In hematemesis, the history usually suggests the likely diagnosis and tests are often not required. Causes of hematemesis are age-dependent in neonate. It is mostly caused by swallowed maternal blood. In infancy, it is mostly caused by drug or reflex esophagitis. In older children, it is mostly caused by drugs, Mallory-Weiss-Tear, esophageal varices, portal hypertension, or peptic ulcer. Upper GIT bleeding may present with hematemesis alone, with the melena alone, or a combination of both. Mallory-Weiss-Tear associated with alcohol binging. It is not that common in children. Gastroesophageal reflux remain one of the most common causes of this tear. In baby with hematemesis, inspection of the mother's breast or expressed milk suggests the diagnosis, and confirmation by APT test performed on the blood aspirated from the stomach. Vomiting blood may be bright red or dark and resemble coffee ground. The latter indicate digestion of the blood by gastric juice. Red flags. Stabilization of the child with the open airway and blood transfusion is urgent. The child may rapidly deteriorate, leading to circulatory collapse. When a newborn has hematemesis or melena, consider if he or she was not given vitamin K. Hemoglobin on admission may not reflect the true hemoglobin level or the blood loss, and therefore frequent HB check is recommended. Hematemesis caused by medication, particularly non-steroidal anti-inflammatory drugs, is underreported and underestimated. It is usually always worth taking a detailed history of recent intake of drugs. The condition is often misdiagnosed as viral gastritis. Aspirin should not be given to children except in certain indications like Kawasaki disease. Parents may not be aware that many over-the-counter cough remedies and analgesics contain aspirin. Mallory-Weiss-Tear, linear laceration at the gastroesophageal junction, may occur after a single episode of vomiting. Children with portal hypertension are at high risk of this tear. Pierce and pitfall. Careful examination the entire skin for the cutaneous vascular malformation that may signal occult GI vascular malformation. Consider accidental toxic ingestion in toddler with upper GI bleeding like iron. Look for signs of portal hypertension such as spider angiomata, palmar erythema, and hepatosplenomegaly as a clue to the possible variceal bleeding. Gastric lavage with the ice or epinephrine is no longer recommended. Thank you for your listening.